Hello, everyone, and welcome to today's Healthcare Provider webinar. Let's talk about sex and breast cancer, navigating tough conversations with your patients. We're glad that you could join us today. My name is Stephanie Washburn, and I'm the Manager of Healthcare Provider Outreach at Living Beyond Breast Cancer, or LBBC. I'm so pleased to serve as your moderator today. In case you're just getting to know us at LBBC, we're a national nonprofit organization that offers trusted information and a community of support to people affected by breast cancer. This program is part of LBBC's Young Women's Initiative, which provides resources tailored to meet the specific needs of women diagnosed with breast cancer before age 45. The Young Women's Initiative began in 2011 when we were awarded a cooperative agreement with the Centers for Disease Control and Prevention to expand our programs for young women. This CDC funding continues today. We selected today's topic because of its importance to people with breast cancer and their providers alike. Our speakers, Dr. Heather Macdonald and Dr. Stephanie Buehler, will help us understand the challenges that patients and providers often experience when communicating about sexual health, as well as resources and approaches to meaningful discussions about sex and breast cancer. We thank Dr. Buehler and Dr. Macdonald for sharing their time and expertise with us today, and you'll learn more about them shortly. We'd like to draw your attention to several LBBC resources that we hope will be helpful. These include videos and blogs with candid insights from young women who share their experiences with breast cancer and sexual health, as well as information about sex and intimacy for people living with metastatic breast cancer. You will receive links by email after the program so you can share the information with your patients and colleagues. Now let's move on to a few final details before the presentation. Today we'll be using the chat feature to connect during the program. You'll see the chat icon at the bottom of your screen. We'll also be using the Q&A feature, which is also located at the bottom of your screen. Please submit questions for our speakers through the Q&A at any time during the presentation. We ask that you frame your questions in a general way so they can be helpful to all participants. We will respond to as many questions as possible after the presentation. For participants who would like to use closed captioning, you can select this feature by clicking the up arrow button next to closed caption or live transcript on the bottom of your screen, or hover over the button. Then click Show Subtitles to start displaying the captions. We will be emailing you a link to an evaluation after the program. Your feedback is very important to us in planning future healthcare provider webinars, and we appreciate you taking the time to share your input with us. If you've registered to receive nursing contact hours or social work CEs for today's program, you are required to participate in the entire live webinar and complete the evaluation by August 17th. You will then be emailed your continuing education certificate by September 7th. Certificates of participation will also be available upon request through the evaluation process for providers from additional disciplines. This activity has been approved by the Ohio Nurses Association, an accredited approver by the American Nurses Credentialing Centers Commission on Accreditation for 1 contact hour, and by the National Association of Social Workers for 1 CE. I would also like to note that no one with the ability to control content of this activity has a relevant financial relationship with an ineligible company. We are recording the session and will post it on lbbc.org about a week from now. We'll notify you via email when the recording is available. Our objectives for today's program are to help providers understand what patients struggle with the most in managing the impact of breast cancer on sexuality, to address what providers struggle with the most in discussing sexuality with their patients, to illustrate the diversity of the patient experience with sexuality and breast cancer, to broaden providers' perceptions and expectations about sexuality and breast cancer while breaking down misconceptions and practicing affirmative care, to highlight the role of communication between patients and their partners, as well as patients and their providers, to provide models to guide providers' conversations with patients and recommend tools they can use in practice, and explain how to help patients connect with other experts for guidance. It's now my pleasure to introduce Dr. Heather Macdonald, the Medical Director of the Hoag Early Risk Assessment Program and the Hoag Breast and Ovarian Cancer Prevention Program. Dr. Macdonald is also Voluntary Assistant Clinical Professor of Surgery at Keck School of Medicine at the University of Southern California. As a board-certified obstetrician gynecologist and fellowship-trained breast surgeon, Dr. Macdonald is unique and provides a holistic approach to women's reproductive health. Dr. Macdonald is an expert in breast disease, including the diagnosis and surgical management of breast cancer, as well as gynecologic issues related to breast disease, including menopause, contraception, breast cancer survivorship, fertility preservation, and inherited breast and ovarian cancer syndromes. Her clinical expertise includes oncoplastic breast conservation, skin and nipple-sparing mastectomies, and intraoperative radiation therapy techniques. Dr. Macdonald is nationally recognized for her expertise in breast disease and continues to publish and speak nationally and internationally on diverse topics. She is a fellow of the American College of Obstetricians and Gynecologists and is a member of the American Society of Breast Surgeons. Dr. Macdonald, we're happy to have you with us today. It's also my pleasure to introduce Dr. Stephanie Buehler, a licensed psychologist, certified sex therapist and supervisor through the American Association of Sexuality Educators, Counselors, and Therapists, and fellow of the International Society for the Study of Women's Sexual Health. Dr. Buehler specializes in women's sexual health, sexuality, chronic illness and cancer, sexual pain disorders, and sexuality and mental health. She has worked with patients in many medical settings, including oncology in a pediatric hospital, an integrated wellness center, a pelvic floor PT clinic, and a clinic for women at high risk for breast and ovarian cancers. Dr. Buehler is the author of several books, including a textbook for mental health professionals. She also provides continuing education in sex therapy for psychotherapists and sexuality counseling for healthcare providers through the Buehler Institute. Dr. Buehler has spoken to lay and professional audiences all over the US and around the globe and is frequently quoted in the media. Welcome, Dr. Buehler and Dr. Macdonald. Please join us on screen to share your presentation. And Dr. Macdonald, I'll now turn things over to you.
Thank you so much, Stephanie, for that generous introduction, and welcome everyone who has joined us this afternoon. We are so excited with the interest in this particular topic that is very near and dear to our hearts. So let's get started. I know Dr. Stephanie Washburn already mentioned this, but we have no financial disclosures relevant to this topic. So everyone I'm talking to knows this already, but to set the stage, we all know breast cancer is incredibly common in the United States, with 1 in 8 women will be diagnosed with breast cancer in their lifetime. The diagnosis peaks in women between ages 50 and 64, and about 5 to 10% of breast cancers are hereditary, meaning most breast cancers are sporadic and unexpected. We know Black women are at the highest risk for developing breast cancer and develop breast cancer approximately 10 years younger than their Caucasian counterparts. They're also at risk for a more virulent form of breast cancer called triple-negative breast cancer. Second highest incidence is in Caucasian women, followed by Hispanic women. Hispanic women also are at risk for breast cancer at a younger age, with average diagnosis younger than 50. Asian, Hispanic, and Native American women have a somewhat lower risk. And Ashkenazi Jewish women especially are at high risk for breast cancer if they have a BRCA mutation. They're actually at high risk of carrying a BRCA mutation, and anyone who carries a genetic mutation is at increased risk of for breast cancer. So today we want to talk about the intersection of breast cancer and sexual health. So the most common experience of a patient is a loss of sexual desire. Our treatments all can also cause vaginal dryness and painful intercourse, difficulty with arousal or orgasm. And there's also an issue of acceptance of physical, emotional changes by the woman and her partner.
Stephanie, I think you may be on mute.
Okay. I'm going to screen sharing. It says I'm screen sharing. And you can see my slides, yes? Okay.
Yes, we can.
Okay, good. Okay, sorry about that. So I'm going to jump in and talk about using the PLISSIT model to think about how to talk to your patients about sex. And this came from a gentleman working at the VA who had to do triage. He was a psychologist. He had to do triage and figure out who he could help fairly quickly and who needed more therapy. Well, the first step he said was to get permission to talk about sex. And I'm going to go through each of these things. So the P in PLISSIT, permission to talk about sex, LI and SS, giving the patient limited information and specific suggestions, IT, intensive therapy. This is when cases don't resolve with information and suggestions, or there's a lot of conflict that's going on in the patient's life, or there's a history of sexual issues prior to the cancer diagnosis. And later, an R was added for referral. So this could be a referral to a certified sex therapist. I'll talk about that in a little bit. A psychiatrist, because a lot of women do have depression and anxiety, a pelvic floor PT in case there is sexual pain, and a sexual medicine specialist in gynecology. Permission. If the client, now I will talk a little bit about couples later, but if a client or patient isn't expecting to talk about sex, then getting permission to talk about it is a great way to get the conversation going. Also, when you ask permission about sex, it makes it seem normal to talk about sex, because guess what? It is normal to talk about sex. We're just not taught how to do that. So hopefully today you'll learn something about how to talk about sex. Ask everyone routinely. Don't make any assumptions about, you have an older patient who's in their 60s, 70s, even 80s. They may still be sexually active, or the partner is still sexually active. Or if they're single, don't think that this person isn't sexually active. And two, you don't know what kind of partner they have. So you need to be affirming. Don't make assumptions that everyone who comes into your healthcare practice is heterosexual. You may have lesbian patients as well. Here are some ways to ask about sex. One of the known impacts of cancer treatment is low sexual desire. Has this had any effect on you? Or cancer affects the lives of many people. We know that. May I ask if your sex life has been affected? Or you may or may not want to talk about your sex life now, but I want to let you know that I'm open to talking about anything, any questions that you have about sexuality. And I have gotten asked this question many times, so I included it. If somebody says, you know what, I don't want to talk about that for whatever reason, you just say, that's okay. Just know that I'm here if questions come up.
So Stephanie, I'm going to jump in.
Yes.
Heather Macdonald. So I'm a gynecologist and breast surgeon, and you would think between those two specialties, I would have had more training in talking about sex than I did, and I really didn't. Now I'm a little older, modern training is a little more inclusive than what I had. But for providers who may be uncomfortable bringing up this subject, and I bring that up because for a long time I was one of those providers, practice makes perfect. And one of the things about making this a routine conversation with your patients and asking permission is, as you do that, you'll become more comfortable with this topic, and then your patients will sense that you are more comfortable with this topic and may come forward and be more comfortable bringing it up. What we know from, we tried not to make this a data-heavy presentation because those can get kind of boring. But what we know from studies is that most patients come all the way through a cancer treatment and report that no one has actually asked about this or talked to them about it at all. and they take their cue from their provider. They're not going to bring it up if they think the provider is uncomfortable talking about it. So just a comment for anyone who may be listening to this and may feel a little personally uncomfortable about raising this topic with a patient. I feel you, I've been you. The more you bring it up, the more comfortable you'll become. And actually it leads to some really kind of touching moments where you can actually see quite a bit of relief on a patient's face that finally someone, they're worried about it and finally someone will talk to them about it.
Right. I would also encourage, thank you. And I would also encourage you, anyone listening, to find someone, a colleague with whom you can practice talking about sex and asking about sex. If you're not used to doing it, you're uncomfortable, practice. That's what will get you into the conversation that needs to happen. And here's the thing. So many, I think one of the reasons people are afraid to ask about sex is that, what are we going to do for them? Well, we're going to give you today information and suggestions that you can, practical things that you can provide to your patients. And then too, if you find out that what is going on is beyond your scope of practice, or it's something that is complex, make a referral, that's fine. Also, if you give those information and suggestions and they don't work, that's your cue. Something is going on. Something is blocking the person, making it difficult to do sometimes the very simple things that you're asking them to do.
So again, on that subject of referral, it certainly takes a village to treat many sexual concerns. And I think sometimes there's a concern about raising this topic if you feel unequipped to answer the question, because we're all uncomfortable with that situation if somebody has a need and we don't know how to meet it. But it's good in advance to look around your community, and key referrals would be a local OBGYN, especially if you look for an OBGYN that specializes particularly in menopause. Most OBGYN training around menopause includes quite a bit of discussion about sexual health. Pelvic floor physical therapist, of course. And then if you're fortunate enough to identify a sex therapist or a sexual relationship therapist that you can partner with, that obviously would be a key connection for you to make.
Okay. I'm going to give you just a piece of education. What is a sex therapist? A sex therapist is a licensed mental health provider, psychologist, a nurse practitioner, psychiatrist. It can be a social worker, MFT, LPC, but they should have specialized training in this topic area. Here are some questions on the basic sexual history. I don't know that I need to go through all these questions. They should be self-evident, I think, but I will comment, it's important to ask if something is bothersome to the woman. She may say that she has low desire, but some women are not bothered by it. So you want to find out, or they're having trouble with orgasm, but they're not bothered by it. It may be the partner who has a problem, in which case you want to refer to a sex therapist who can talk to the couple about what's going on. And the last question here, and I'm jumping in the interest of time, but that last question, what are you hoping will happen as a result of help for this problem? That's where you can find out whether their expectations are realistic, whether they are, if they say, I'm expecting to get back to my good old sex life. You don't want to squash that and say, I don't know if that's possible, but you do want to keep it in mind, because at some point the conversation may need to happen that things have changed and you're going to have to make changes in your sex life as well. I think too, Dr. Macdonald and I talked about this quite a bit, that sometimes healthcare providers are perhaps afraid to ask the question because they're afraid they're going to open the floodgate. That, all kinds, really, it is true. When you're talking about sex, all kinds of things can come up, but you're not required to treat those things, to answer every question that they might have. You can have people on your team. And as I said, sex therapists, a very important person for your team, the American Association for Sexuality Educators, Counselors, and Therapists, or the Society for Sex Therapy and Research. Great places to find referrals for sex therapy. And again, the pelvic floor PT, looking at the Academy of American and Physical Health. Psychological changes that can occur. I don't think this one is a surprise. It's listed here, but grief over the loss of the breast. In our culture, especially, the breast is a symbol of femininity. When women develop breasts, that's a sign that they're becoming a woman. It's a sign of attractiveness. It can be a source of pleasure for not all women, but some women. And when the breast is lost, there can be a true sense of grief. There can also be possible hair loss, and grief can come along with that. Hair loss is associated with being attractive and youthful. Anxiety and depression are common for survivors who want to find out ask about their mood, ask how they're coping with things so that you can make an appropriate referral. There can be fatigue and sleep disturbance. And once again, I think psychotherapists are underutilized for helping people attain good quality of sleep. So there are many things that we can do to help people with sleep that don't require any kind of pharmaceutical intervention. And last but not least, there's chemo brain. Many people complain that they have sort of a brain fog that happens, and just helping them cope with that, and even making suggestions about figuring out when to do things, what time of day to do things when they're sharpest, and so on.
So I want to add one comment to that comment about insomnia and fatigue, and 100% our mental health colleagues can be helpful with that. There's some interesting data regarding cognitive behavioral therapy, or CBT, and insomnia, that actually the response rates are equivalent to any pill that we can prescribe. And as a prescriber, that is really important to me, because our safety data around pills like Ambien and Lunesta really only goes for several months to a year. So for women who are relying on this for long-term treatments, we really don't know what it's doing. And many of our cancer survivors, by the time they've come through a cancer treatment, they feel like a walking pharmacy already, and they don't want a pharmaceutical solution to every problem. Which I wholeheartedly support. So cognitive behavioral therapy is a fantastic intervention, literally retraining the brain to go to sleep. I could spend an hour talking about it, but I won't in the interest of time. It is a very particular skill. There's actually a certification for psychologists to do cognitive behavioral therapy. At least in California, there's a wonderful website, psychology.com, where you can literally pull up who the certified providers are in your area. It lists who takes insurances. I literally just put my patients on that website and help them find a therapist who is convenient for them. So that's a little pearl from a provider who often has a 15, 20-minute visit with which to tackle all of this. And insomnia is a challenge for breast cancer survivors. But that is something I have relied on increasingly with good data behind it. So other sexual changes, obviously, this may be due to treatment, this may be due to psychological issues, but don't rule out medications. We all know antidepressants many of them can lower libido. So while we're treating the depression, are we increasing one problem while we solve another? Low sex drive, again, is the most common complaint of most survivors. They can have difficulty with arousal and orgasm. Vaginal dryness is a very common and persistent complaint among our breast cancer survivors. The anti-estrogen therapies that all patients with hormone-positive disease end up taking for 5 to 10 years all cause vaginal dryness due to low estrogen levels. Even tamoxifen, which works differently, increases vaginal discharge, ironically can cause vaginal dryness, which sounds like it doesn't make sense, but it's common. And all of this can cause painful intercourse. So while we certainly don't discuss often enough these mental health changes associated with sexuality, there are, true underlying physical changes as well. The other one I'll comment on is after breast surgery and reconstruction, breasts are often numb. And that numbness is something when you talk to women after that reconstruction surgery, the women who were not adequately prepared, I'll say it's the one thing they wish they had known. That doesn't necessarily mean they regret decisions that they made, but it's an expectation that we surgeons need to do a better job of preparing patients for, but something certainly to keep in mind.
Yeah, definitely. As someone who has received referrals from Dr. Macdonald, many other physicians and healthcare providers, women come in and they are shocked sometimes at the vaginal dryness that they've experienced. No one has told them that this was a possibility. So having information ahead of time, not to, you don't want to frighten somebody from taking steps, but just, informing them that this is a possibility. And if it comes up, don't worry about it. There are some solutions and we can talk about what to do. So it's not just saying this is going to happen. It's we can help you with that and give them a heads up. It's very welcome.
The other comment I just want to add, and this is from a physician, I realize I walk into a room with my white coat and we talk a lot about the physical changes of treating cancer, the vaginal dryness, the numbness, scar tissue, pain from surgery, that kind of thing. And I realize on our call today are a number of social workers and nurses. And often I think you are the ones the patients mention some of the less physically based complaints with. And I think that's marvelous. I think it takes a village to treat a patient, and anyone the patient is comfortable talking to should have someone that they can mention this to. But I just throw that out there to acknowledge it's often, to the doctor, they mention pain, they mention vaginal dryness, but the arousal and libido issues, they may actually be much more comfortable talking to a nurse.
Right. Yes, and I also want to acknowledge that there are oncology social workers, and certainly I include you under the umbrella of healthcare providers. Okay, let's see. Get my slide change there. So tricky on the mouse there. Let's see, where am I? So here we are. So what do we mean by sex? We're talking about sex, we're talking about sexuality. And here's the thing, that most heterosexual people think sex means intercourse, that they mean penis vagina intercourse when they say that they're having sex. But sex includes a wide variety of experiences. So sex can be easier for survivors and their partners if it includes what we call outer course. So that it can be heavy petting. It can be, rubbing up against each other. It can be manual sex. It could be oral sex and using a toy, which I'll talk about in a little bit. But if you talk more about, there are all kinds of different ways of having sex that maybe takes less energy. Maybe, if intercourse is painful or there are fears about it being painful, then, to do other kinds of activities can be helpful, and put the emphasis on pleasure and emotional intimacy and off of having to have intercourse in order to have sex. Intimacy includes just having a conversation, joking with each other, reminiscing about things that you once did, sharing a meal, cooking a meal, taking a shower together, having a massage, enjoying some activity, going bowling if that's your thing, or just being together and being quiet somewhere. All these things engender intimacy, and saying, what, this is a good time to connect emotionally and let each other know how important you are to one another if you are working with a couple.
Can I jump in, Stephanie, and just make the comment of sometimes you're having this conversation with the patient and either she explicitly states or you get the sense that you're kind of preaching to the choir, and that your patient herself may embrace this idea, but she may be really uncomfortable about either speaking to her partner about this or really concerned that her partner has a much more specific definition of the intimacy that the partner is looking for. And if that is your sense, then that is the perfect couple to refer, because then that is exactly what a sex therapist will do, is to talk to the couple and help them set some expectations together. So just pointing out, that is one that's probably the most common moment that I end up referring a patient to a sex therapist.
Right. And the other thing too, I know Dr. Macdonald and I had a conversation about this, that, people's idea about what good sex is supposed to look like is really kind of based on this Hollywood model of having sex, that you look at each other with hungry eyes and the clothes fly off, and there's intercourse and the woman has an orgasm in 30 seconds, and that, but that's not real. So sometimes having a conversation about that and saying, sex can be so many different things, and that is what the new normal is. Saying like things have changed, but that doesn't, just because things have changed doesn't mean that things are bad. It just means that you have to do things differently. You may have to talk about what feels good to your body now. I know I worked with one woman who said she needed a long period of back massage before, just lying on her tummy, having her partner just rub her back for a really long time before she could feel herself just relax. One of the survivors I worked with, telling your patient, or if you have the partner there as well, talking about the fact that there is grieving the way that your sex life was, because some of the spontaneity may not be there, or if things are painful, or there's fatigue, that the activities may change. But change is not bad, it's just different. And so you're going to adopt to the new normal. And as I said, making the focus on intimacy and connection instead of intercourse and orgasm.
So this is a little similar to what we've said. It's normal to have sex of any kind, less frequency after treatment for breast cancer or for any form of cancer. And a lot of this gets to expectations, finding out what the expectations of your patients are. I'm sure Stephanie knows this better than I, but when they do surveys of how often does the usual American couple have sex in a week, it's far lower than everybody thinks everyone else is having it. So everyone has this perhaps unreasonable expectation, or everyone seems to know the one couple that seems to have sex every day, and then somehow that becomes the goal of what everybody does. So defining normal is always a thing. And then, like Stephanie mentioned, a new normal. However, there are some other sort of treatment-related changes in desire as well. So many, especially our young women, go into menopause as they're going through breast cancer and treatment, and that is going through breast cancer treatment, menopause because of breast cancer treatment is the hardest and most symptomatic way to do this. Menopause is supposed to be a 7-year process, not a surgical process, not a you had chemotherapy and within a month everything shut down process, not a your medical oncologist is giving you an injection every month that has dropped all of your hormone levels process. So vaginal dryness is actually a late side effect. The early side effects of all of that are more hot flushes, insomnia, moodiness, but also changes in feeling desirable or changes in arousal or ability to have an orgasm. That's actually an early change and not one that we tend to educate our patients about very well. Many, all women at this point with breast cancer have undergone surgery. And so we are operating on a very personal and private part of the body. There may be changes in body image. No matter how brilliant our breast or plastic surgeons are, an operated breast is not going to look like it did before. So there's some recognizing sort of the body that you're in. We've talked depression and anxiety and stress, of course, are very common in our breast cancer patients. And then all the medications we use, including the antidepressants, also impact desire. So desire is kind of the bottom of a funnel with many, many things that impact it. And there are many causes, and sort of getting to some of those causes are important. If it's a medication, maybe there's a different medication we can use that has less impact on arousal, or if the problem really is depression and anxiety, maybe we actually tackle that and it allows a patient to connect with that part of herself again. Our sex therapists are also wonderful at talking to women who are struggling with that change in their body image. So that is probably the second most common reason I refer patients to sex therapists. And in fact, if there's time to do it before I perform breast surgery, and these are usually our BRCA carriers who are having preventative mastectomies, I actually recommend they talk to the sex therapist before and after surgeries to prepare them for what may be coming ahead, and make sure they have language to talk to their partners about this. So, Dr. Buehler, I'm actually going to have you, this is all information I learned from you, so I'm going to have to go over this slide.
Okay, great. So what to do about these changes in desire? Well, sex therapists very often, I cannot tell you how often we recommend when a partner has low desire to schedule sex. There are a number of different reasons for that. One is that it helps the partners kind of circumnavigate repeat conversations. They both know what's supposed to happen and when it's supposed to happen. They don't have to argue about it. And hopefully it becomes something that they look forward to. Sometimes it gets, takes some getting used to the idea of having intentional sex. But once you start doing it, you just figure out like, okay, it's time to show up. And we're here and we're going to be present and we're going to have an enjoyable time. One of my mentors, Barry McCarthy, frequently said to couples who balked about the idea of scheduling sex, would say, well, you don't, if you have tickets to the ball game or you have tickets to a play or a concert, you don't look forward to it any less, do you? So, so you can have that little retort ready in your pocket. But I also think it's important to help a woman understand herself. If there is no longer the biological urge, or physical urge or psychological urge that is making a woman want to have sex, then there are things that she can do to maybe tune into her need to connect, to be sexual, to have a certain kind of intimate experience with her partner. And it can be different things for different women. Some women find, going to have a massage or having a pedicure, or, saying to their partner, if there are children in the home, to say, please take care of the children for Saturday, and I'm going to take that time to relax so that I can be present for you Saturday evening. Whatever a woman identifies that she needs, and communicating that to her partner. And also in that, determining what she needs from her partner. So at this time, if there have been physical changes to the body, emotional changes that have happened, maybe partner has traditionally given her a pinch on the butt, and that's the way that he says, I'm interested, or even she says, I'm interested. That maybe is not going to work. Maybe it was cute before, but the woman is in a different place psychologically, physically. Okay, so that's okay. What do you want now? Well, I want to sit down on the sofa and just cuddle up together and feel close before we go into the bedroom. It could be something like that. It could be changes in how she wants her body to be touched. Some women, if they've had reconstructed breasts, some women want the breasts to be touched, some do not. Some, there may need to be some experimentation to see if it feels good or not. That's okay. It can happen slowly. You can suggest that they wear a little clothing, a camisole, something of that nature, as they're doing some experimentation to see what feels good and what no longer feels the same or doesn't feel good anymore. And also, what kind of encouragement does she need from her partner? She wants to feel more desirable. What does she need him to say or her to say to make her feel that she's still in the game, that she's still desirable, that she's still sexy? it's not breasts that make a woman. It's the whole being that makes a woman. Maybe she needs to hear some of the things that her partner really appreciates about her.
So Dr. Buehler, before we go off this slide, I just wanted to highlight that top section, determine what helps a woman feel more desirable. We've spent quite a bit of time talking today about partners and couples, and that's absolutely important. But I just want to point out that much of the things on this slide actually don't have to have anything to do with the partner. That, a woman's relationship with her own body, especially for our unpartnered patients, while it's important when we're talking to them about sex to know if there is a partner involved, for our unpartnered patients, it's still a woman's relationship to herself. And so some of these recommendations for women who feel very disconnected from their body, even if they don't have a partner who's involved, are important for just making her more comfortable again in her own skin.
Super important. Okay. And
I touched on this a little bit, changes in the breast, scarring or losing the breast or breasts affects women very differently. I've certainly had patients who have mourned the loss of their breast for many years and continue to. And I have other patients who say, that was not a strong sexual organ for me. That was not something I was particularly attached to. Some women have rituals they go through before breast surgery, particularly if it's a mastectomy, where they and their partner, kind of thank you for your service a little bit. Thank you for breastfeeding my children, if that was something they did, and acknowledge that change in their body. But other women don't find that change from surgery as significant. So again, I like this idea where you start by asking for permission, as it invites her to let you in on kind of what is it about this that she's experiencing, because it can be very, very different. Also, the different surgeries have very different impacts. So breast conservation surgery, where we've just done a lumpectomy and maybe remodeled the remaining breast so it's still breast shaped, is going to have a lot less impact on sensation than a mastectomy and a reconstruction. No matter how brilliant our reconstructive surgeons are, a reconstructed breast is essentially a placeholder in clothes. It does not feel the same to the patient or her partner. The texture is not the same. And in over 70% of patients, the sensation is either entirely diminished or gone. And often it's a weird combination of numb and highly sensitive, and it doesn't actually feel good to be touched anymore. So, talking a patient through that, sometimes our lumpectomy patients we forget that, you saved your breast, but I've had some lumpectomy patients, especially if they've had a significant breast reduction due to the amount of tissue we had to remove, who, mourn their closet. I had a patient who went home and said she's sad. She took all the clothes down in her closet and cried because her favorite clothes didn't fit her anymore. There's a real process to this. So just allowing a patient to share that can give you a lot of information of how to direct her.
I think too, what I would like to comment on this slide is that, again, encouraging exploration of the body. If the breasts were a source of pleasure, find out what's sensitive. Maybe what's sensitive now, what has changed, maybe it's the skin on your neck, or it's the skin on your upper thigh, or it's your buttocks, or, just trying to find where are the other sources of erotic pleasure. And so there we go. This is just what I said. I think this is your slide, or maybe we talked about this already a bit.
Yes, I think we have.
Okay. I wanted to talk about changes in orgasm because of fatigue, taking medications, changes in the genitals. It can become more difficult to have orgasm. And for most women, if they have been orgasmic in the past, they will continue to be orgasmic, but they need to be educated and told that, they may need a longer period of foreplay. That may be, going forward, It may just be for the present time as the woman is healing, her body is healing, she's healing psychologically, trying to process the changes that have happened to her. But, talking about the need for longer periods of foreplay, and also maybe adding a vibrator. Even if a woman has not used a vibrator in the past, adding in a vibrator, either it can be used before, during, after penetration, or just alone, just as, part of outer course, that using a vibrator can make it easier to have an orgasm. So, if a woman says, oh my God, it's taking me 20 minutes or 30 minutes, try adding a vibrator. That may shorten things down for you so that you're not, just like a sweaty mess by the time you finally have an orgasm. And then you can educate women that 70% of women in the US actually own more than one vibrator. You can now go to Target and get a vibrator. They're just very common. And encourage the woman to talk openly with her partner. Sometimes partners feel threatened about the introduction of a vibrator. That's another time to maybe make a referral to a sex therapist who can talk about why the partner is feeling that way. Sometimes those feelings predate the cancer diagnosis. And so being able to talk those through, it can be very important. Oh, I think I skipped a slide. I did, sorry.
So I wanted to just throw a few slides in here. This is my gynecology self talking now, about how do we actually manage the genitourinary symptoms of menopause. This used to be called vaginal atrophy. But as estrogen levels fall, the tissue that lines the vaginal canal can become thin and friable and non-distensible. And if you think about what a vagina should be for either childbearing or penetrative intercourse, it should be distensible, it should be elastic, it should be lubricated. And during menopause, it's sort of all those things go away. So vaginal dryness, vaginal burning, pain with sex, urinary frequency, pain with urination, blood in the urine, recurrent infections, dribbling, none of which makes anyone feel sexy at all. But there are some sort of basic over-the-counter solutions that are reasonable to start with. And I wanted to just throw that information out there in case it's helpful. So what we recommend for women who have any of that list of complaints, and hopefully they all have a gynecologist and they've seen a gynecologist. And if any of these interventions don't work, they definitely need to see a gynecologist. But things that are kind of easy and basic to start with, eliminate all irritants from the area. And that includes spermicides. That actually includes soap of just about any kind. That includes body soaps. That includes laundry soaps. And if you start talking to women, you can ask them to think about how many different chemicals is your vaginal area encountering and minimize them. The laundry soap that I recommend my patients to use is either, and again, if I were a smarter woman, I'd be paid by companies for saying this, but I don't have that kind of intelligence. Dreft, which is the pink, in a pink bottle on the market, which is what we use for newborns, has a newborn baby on it. That is probably the least caustic laundry soap on the market. Woolite, or anything you use to wash by hand, also is a lot less caustic. So I recommend all my patients wash your undergarments in either Woolite or Dreft, and that can certainly help with the irritation. And I actually recommend when you're in the shower washing with body soap, you do not need to wash your vaginal area. It is like a self-cleaning oven is my personal favorite phrase that I'm borrowing from somebody else. And if the area is irritated, just don't wash it. Water's fine, but don't use any kind of soap. We also recommend ongoing stimulation, and Dr. Buehler has given us a wonderful list of ideas we can share with people for both people with partners, but also without partners. This is really a use it or lose it situation. And so encourage women to continue stimulation. And that's, again, with a partner or by themselves, masturbation, vibrators, or with a partner, with either one of those things. Smoking cessation, we can add this to the laundry list of reasons why we encourage our patients to stop smoking. And I don't know, this is a high stakes situation. So maybe a few people will stop smoking so they can improve their sexual health. And then that's a win all around. And then also to think about loose clothing. I think we all kind of learned this when we were going through puberty, but infections like dark, warm, sweaty areas. I wear Spanx just like everyone else to wear these like, you know, figure hugging, clingy clothes that are in style right now, but that is the perfect setup for a vaginal infection. So encourage women to think about their vaginal hygiene in terms of the clothes that they're wearing. I included a list of alternative medications because I think we all need to know what our patients are using. This is not a list of recommendations, and maybe I should make that more clear. This is a list of what our patients are finding on the internet and at their local stores and using to try and treat these issues. There is a little bit of data around things like black cohosh and wild yam, that they have a natural form of estrogen, but we also know that plant estrogens are very weak binders of an estrogen receptor, which is why for my breast cancer patients, I'm not really worried about them using it, but I also don't think they do much other than just provide some external lubrication. And I'll give you a cautionary tale about black cohosh. The initial studies that tried to look at the safety of black cohosh could not find a consistent compound between the herbal products labeled as black cohosh that was in high enough quantities across different products to be tested. So a lot of this is marketing. A lot of this is who knows what they put in a bag. I'm in California. I have a lot of patients who want to use an herbal approach. I just make sure they're very, very careful where they source it from, because there really is no one watching to see what this stuff is sold by. The other cautionary approach I'll mention here is vitamin E. Vitamin E is a fat-soluble vitamin, and if you overdose on vitamin E, it gets in your fatty tissues and then releases slowly over time. So vitamin E is something to be used very cautiously. It's also very pro-inflammatory. Like, it was very in vogue to put on surgical incisions a while ago, and we would see these surgical incisions that were hugely red and inflamed. So I'm not a big proponent of vitamin E at all. And then there's a huge study that came out recently that showed that vitamin D actually has very little bioactivity from what we were hoping it would do. So there's really no reason to recommend it. What we're trying to do is increase vaginal tissue flexibility, which some of these projects do mostly just by physical lubrication, but they don't really change the symptoms. So next slide. This is sorry, go ahead.
I'm so sorry, excuse me, Dr. Oh, go ahead.
I think this is yours.
Yes. So the next slide, this is kind of my secret little list. Again, I don't get any money from any of these companies, but all of these things have been kind of vetted by gynecologists, by the National Association for Menopause. And for topical use, they're available over the counter. This is literally the slide that I give my own patients of how to start, that doesn't bind estrogen receptors, that won't interfere with any other treatments that they're on. So things to know, moisturizers and lubricants are the absolute mainstay of all of this, and patients need to read labels carefully. Anything with alcohol or perfume is incredibly irritating and to be avoided, and you would be perhaps not shocked to find out how many products are marketed to women that are full of alcohol and perfume. So moisturizers are used for a maintenance therapy every 2 to 3 days. You want to actually mimic the slightly acidic pH of natural vaginal secretions. So Refresh is a product that does that. Then there's various products that actually bind the vaginal epithelium, bind water, and rehydrate. Hyaluronic acid, you may recognize that. A lot of us use it on our faces. It actually works really well on vaginal tissue. And some of those product names are there. Again, I don't make any money off this. This is just where I send my own patients for relief. So then lubricants are used for intercourse or for very symptomatic patients. They can have vaginal dryness even walking down a sidewalk. Sometimes it's used daily for that. Silicone-based products will last longer than water-based products. Glycerin-based products, of which you recognize some things we use in the office like KY jelly, can actually exacerbate recurrent infections. So I warn patients about that. Again, I'm in California. We like everything organic. So olive oils and coconut oils actually work really well. I have a number of patients who swear by Trader Joe's coconut oil. However, there is some question if she has recurrent vaginal infections, is it possible we're making that worse? And then I wouldn't be a gynecologist if I didn't include a comment that all of this can weaken latex condoms. So if we have patients who are not monogamous and are relying on latex condoms for protection from sexual transmitted infections, they need to be aware that some of these products will actually weaken the condom. Then my final comment there down at the bottom is early and often refer to pelvic floor physical therapy. If this is especially a long-standing problem where she has learned a fair amount of pelvic tightness in relationship to a chronic painful intercourse, our physical therapists actually are key to retraining her body to relax.
Excuse me, Dr. Macdonald and Dr. Buehler, I just wanted to let you know we have about 5 minutes left until we'd like to aim for Q&A, but please also do take the time that you need for your slides. Thanks.
I think we're pretty on track. So yeah, that's good. Yes. Okay. So I so appreciate Dr. Macdonald mentioning frequently single women, and not overlooking their sexual needs. And when I say couples, I'm inclusive. I mean, whether they are heterosexual couples or lesbian couples, or even, well, I can get into like lots of things there, but we'll just say couples, that you want to encourage them to have open communication about sex, to have kitchen tables talks, right after you've tried to have sex, intercourse, if that's what you're going for, or any kind of sexual activity, and things just did not go as expected. That is not a great time to talk about, what are we doing about our sex life? That's a great time to say, you know what, let's get some sleep and let's talk about this when we're both rested, and really putting aside time and giving this topic the attention that it deserves. And each partner can take turns talking about how they feel about the changes that have happened in their sex life and what they would like to do about it. And if they need to bring in another party to help them with that, whether it's their healthcare provider or sex therapist, that would be a good time for them to talk about that together. Normalize all of their feelings regarding sexual changes. There can be frustration, there can be anger, there can be grief, there can be confusion, there can, all kinds of feelings can come up. Those feelings are all normal. There should be expression of those feelings and not feel defensive about them, and just to acknowledge that those feelings are there can be really helpful. Again, redefining sex as being more than intercourse, talking to the couple about expanding their sexual repertoire and establishing that new normal, very important.
Okay, so following up, after you've successfully broached this topic and your patient's been comfortable sharing with you what's going on, obviously this, like every complaint that we follow up in medicine, should have follow-up. Did what we suggest work? Did it help? If not, why not? And what might be the next step? Sometimes it's just reinforcing what our patients have been told. Our patients who are being treated for breast cancer are just inundated with so much information all the time that often you have reviewed something and they have very little memory of it. In fact, my second consultation with a breast cancer patient, I just literally start at the beginning and go over the whole thing again, because it takes, this is a whole language that they're not used to hearing, that this is an emotional topic. It takes a lot for this information to sink in. So sometimes just reinforcing what was talked about before, give some additional suggestions. And then if really the suggestions aren't working, or if you're uncovering perhaps a problem that pre-existed before the cancer diagnosis, or specifically, I'm going to circle back to what Dr. Buehler mentioned before about conflict. If you are getting a sense that there is quite a bit of conflict in the patient's life or in her relationship around this issue, refer early, refer often. Our social workers, I know, have training in this, and I salute you as a surgeon and a gynecologist. I fully understand my own limitations, and I happily pull in my mental health colleagues for help. So to recap, just a few statements. It is the responsibility of, it is our responsibility to ask the patient about sex. And that is because patients in time and survey after survey will acknowledge that they won't bring it up if we don't. We need to signal to them that it's something that we can talk about. The PLIST model is a great framework for determining what level of sexual health care is needed that Dr. Buehler went over. And again, this presentation will be available to you so you can have that. Changes in desire and orgasm and genital health are the most common. Information and suggestions can actually help resolve many, many issues. And then, of course, referrals can be made when problems do not resolve with that information or suggestion, or the problem is outside your scope of practice. So, Dr. Buehler, do you have any words of wisdom to add?
I would just say, you know, once again, I really appreciate all of the people that have shown up today to listen and to take the time out of your day to listen to this talk, to learn more about how you can help your patients with sexual concerns. You are really the first stop for these issues, and you can do so much to help them with their quality of life. I really appreciate that.
Yes, we certainly wouldn't want anyone, even in a successful cancer treatment regimen, to lose this most important part of their life. So I think on our last slide, this is our contact information. This is how you can reach both Dr. Buehler and myself. I know we have some time for questions and answers, but we did want to make ourselves available. I'm a big believer in curbsides. I do it all the time. When I have a particularly confounding situation, reach out, phone a friend. So this is how you might reach either one of us. And I'm going to turn this back over to Stephanie there's like so much going on in the chat. I've been trying to watch, but I'm interested to see.
Oh, I have mine turned off. No.
There's great things flying by. I'm like, whoa, what was that?
Great. Thank you both so much. And for this amazing information. It is so valuable. We have been hearing from providers and participants in the chat about how valuable it is to them in their practice. And thank you for making yourselves available to and sharing your contact information. So we have about 10 minutes for Q&A. We have a lot of amazing questions from our audience. So I've been trying to watch that as well and look at the flow of questions coming in and try to isolate some of them because I don't think we will be able to get to all. One that came up I thought was really interesting, and I wonder if either or both of you could comment on this, is the question of men and breast cancer. And if either of you have direct experience working with men and partners, if they have them, or just men as individuals dealing with their diagnosis and sexuality.
So as an OBGYN, I thought I had signed off on that entire gender. And then I have treated a number of male patients for breast cancer. I think actually the one comment I would make, and I'll keep it brief, is I think this issue is even more complicated for them because they've kind of wandered into this pink and feminine world. And it's hard for them to find their place and where they're comfortable being treated, much less talk about some of these issues. So if anything, I think we have to double down on making sure that they realize what's available to them, that all of this is available to them, but in a way that's comfortable for them and sort of sensitive to the fact that they may already feel a little out of place.
I would say, I'm going to say over the years that I've worked in sex therapy, I have had very, very few men with breast cancer in my practice. I think there are a lot of different reasons for that. But the men who have come in, men enjoy their breasts being touched also, and they struggle with body image as well. So, thank you for bringing that up. As far as I think many of the suggestions that were made here about low desire, scheduling time, those kinds of things, dealing with fatigue or depression and anxiety, those are more the things that may come up from a psychological standpoint.
Great. Thank you both so much for addressing that. And thank you, as you said, to our audience member who brought that important question up. There was another question I noticed, there might have been more than one, from a provider. I don't know if they live in an area that specifically may have a little bit less access to resources, perhaps it's rural, I'm not sure. But in wanting to refer patients on for additional support, whether that's with a pelvic floor PT or a sex therapist, I know this is a complicated question. Do you have any suggestions on how people can help, how providers can help their patients find those resources if they're maybe not at all, close to or part of a large academic medical center or otherwise have easy access?
Yeah, so with one of the few silver linings of COVID is that most mental health providers these days are still doing telemental health. And so I would just connect with somebody within your state. Our licensing as mental health providers is kind of strict. We have to, for the most part, we have to practice within our state. But if you go to ASECT, AASECT, or STAR, SSTAR, you can find practitioners in your state. I would get in touch with them.
Okay, awesome. Thank you. That's great. Is there anything, Dr. Macdonald, you would also want to add?
Nope,
No?
that was
Okay.
what I was going to say.
All right, very good. Bear with me just a moment. I'm going to go back to our questions list because they are coming in as we're talking. So I just want to make sure I keep an eye on as many as possible. Somebody asked, can you speak to cultural differences, any things to take into consideration?
Well, that could be a whole nother topic and an incredibly important one. I'll share with you that a substantial part of my practice I spent at a county hospital with a primarily Hispanic, primarily Catholic religious patient population. And yes, that is going to take a very different approach and a sensitive approach. And this is what I like so much about the way Dr. Buehler presented that model, is I think it's the idea of permission. It's, of course, we should, as providers, we should all be in tune with, the various cultural sensitivities of the patients that we're treating. But I think just that idea of starting with permission as you approach this subject just demonstrates a respect for wherever your patient is coming from, and also puts them in a little bit of control of where this conversation goes. We all know our cancer survivors, their number one experience of having cancer is feeling a loss of control. And so anything that we can do that acknowledges that and allows them to stay sort of within their comfort zone is important. Off the top of my head, that's always
Yes.
my first thought.
Yes, absolutely, all of that. And I think you can, like if there's discomfort, you can just open up tell me about well, hopefully you've educated yourself. You might have some cultural humility and have educated yourself about the cultures of the people that you've worked with. The people that I worked with in Orange County may be very different than the people that somebody's working with in Washington State. So, but to say, culture can have an effect on how easy it is to talk about sex. So if this is difficult for you, tell me a little bit about your upbringing. If it seems complex, once again, I would refer, somebody who comes, Orange County is actually very cosmopolitan. We get people from all over the world, and having conversations about culture and sexuality can go on for a long time. So, make those referrals.
Another comment about that I've utilized quite a bit is I treat quite a few patients where there's a language barrier. We have quite a few 8 different Asian populations in Orange County, California, and I don't speak any of those languages. And if this is an awkward conversation to have, having it through a translator, especially in many of these families, they prefer a family member to be a translator. So one of the ways that I've successfully invited a patient or given her another avenue is most of my patients at least have an email address that will auto-translate. And so all of my patients have my email address anyway. But some of the most sensitive questions I've gotten from non-English speaking patients where I don't share their language actually has come through the email. And I think that is because having a three-way conversation with a translator, either a stranger or a family member, feels even more awkward and uncomfortable. So another thought would be making yourself, if you're comfortable with it, available in multiple ways to your patients, where a face-to-face conversation for one reason or another may not be what they would choose, but there are other ways to communicate.
Great. Thank you so much for those very thoughtful suggestions. That's a complicated topic, and I really appreciate you answering so clearly on that. There was a really interesting question about partners, and I know you both talked a good amount about partners and couples. I'm wondering if you could touch on this a bit more. This audience member wrote in, what about the partners who are afraid of sex and intimacy, afraid of hurting their partner, afraid of doing something wrong? How do we positively help these partners?
So can I share just a super fast little anecdote? In our prevention program, like I said, we recommend all our patients who are going through a preventive bilateral mastectomy for something like BRCA, meet with our sex therapist before and after surgery. It's part of the education about anticipating what may change. And many times I have a woman, we're talking about mastectomy. She has a very supportive, loving partner with her. And I introduced the idea, I just presented as this is part of our program and this is part of our pre-op process. And then I can see this massive wave of relief on his face because clearly he's worried about it, but he doesn't want to be that guy. Everyone's talking about cancer and saving her life, and he's worried about sex and he doesn't know how to approach that. So then I say, you know, I bring it up, he's happy. And then I recommend they go as a couple, because one of the most important things our therapists do with these couples is make sure they have language to talk to each other about how things may change. And if you want to be touched differently and all the things that Dr. Buehler talked about. And then for some of our partners, and this is usually not to pick on men, but usually they're male partners who do this, their face just kind of freezes in horror, like, what? I have to go talk to who about what? And then that gives me the clue, like, oh boy, you really need to go. If you're this nervous about talking about it, we're really going to be able to help you here. So I try and introduce it when patients are that nervous about it. I focus more on the communication aspect than sort of talking about the actual act of sex, and frame it more of this is helping you guys learn how to talk about this to each other rather than you're going to therapy. And whether that works or not, we successfully do have many of our patients kind of complete this. So that's a little trick that sometimes works for me.
Right.
Great. That's super helpful. Thank you so much, Dr. Macdonald.
If I
Dr.
can just quickly say, you know, having a cancer diagnosis can bring up a lot of existential issues, both for the cancer patient and for the partner. Sometimes I've had cancer survivors not want to engage sexually because they're afraid, you know, they don't want their partner to become too attached to them. I've also had partners who are afraid to become attached. There can be deep issues that are happening. And so this is where the Plicit model is so good, because we give this information, give them suggestions, they're not following through. That's indicative that, you know, having another person, a third objective party, can be really helpful.
Great. Thank you. And thank you for bringing us back to that model again, too, because I know you have found it so useful. So somehow our time together has flown. You are both amazing. I could listen to you all day, and I suspect our audience could do the same, and I'm sure your patients do as well. So on behalf of Living Beyond Breast Cancer, I'd like to thank you both very deeply for all the time that you have given us today and for all that you do for people with cancer and their partners. I'd like to also recognize the Centers for Disease Control and Prevention for their support of this program. And as a reminder to our audience, I should say first, a thanks to our audience for coming and being so engaged. So first, a thank you. And second, a reminder that you will get an evaluation link today. Please remember to complete it no later than August 17th. We're going to also place the link in the chat for anybody who'd like to do it as we're wrapping up. For those of you who request contact hours, CEs, or a certificate of participation, you'll be emailed your certificate by September 7th. We're also going to send a link to the program recording by the end of next week. So thank you again, all of you, for joining us today and for the care that you provide to people affected by breast cancer. We hope you will also participate in future LBBC programs. Please take good care and enjoy the rest of your day.
Thank you.
Thank you.
Thanks.
This concludes today's program. You may disconnect at this time. Thank you for your participation.